The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/QYX860. Downloadable slides and practice aids are also available.
Greetings and welcome to Optimizing Precision Medicine in Ovarian Cancer, expert insights on clinical implications of Parp inhibitors and companion diagnostics. My name is Brad Monk. I'm a gynecologic oncologist from Phoenix, Arizona, professor, Arizona Oncology, Creighton and University of Arizona. And I'm joined by my colleague and friend, Dr. Katie Moore. I think all of you are familiar with Dr. Moore from the University of Oklahoma. Katie, welcome.
Thank you so much for having me, Brad. I'm excited to be here.
Yeah, this is great. Well, thank you. And I'm also joined by my good friend on the West Coast, BJ Reimel from Cedars-Sinai Medical Center. Greetings, BJ. Thank you.
Hi, Brad. Great to see you.
Yeah, my pleasure. This is going to be a lot of fun. So we'll cover tonight the biology as well as the rationale for Parp inhibitors as a therapeutic and maintenance strategy in ovarian cancer. The idea really is to translate the science, the clinical trials, into real-world opportunities for our patients, because that's why we do this, is for patients. So we're going to present some cases and hopefully have a lively discussion amongst the three of us. I think we all realize that the DNA damage response pathway is an oncologic target, that when double-stranded DNA breaks are created, apoptosis results and the cell dies. We realize that the BRCA gene was pivotal to this opportunity, but it was beyond BRCA. And you're going to hear a lot about sort of the beyond BRCA opportunity, which is where not only BRCA, but other BRCA-like genes prevent double-stranded DNA from being repaired. And what that really is taking a sister chromatid, lining it up to the homolog, and then recombining that double-stranded break. So we're going to talk about that. And the reason Parp inhibitors work is because they create double-stranded breaks, and they do so by inhibiting single-stranded DNA repair. So this has been a wonderful journey. 9 indications, if you can imagine, in just over 5 years. We have 2 new indications here in 2020, I think, that are really important for patients and really important to understand and to apply really at the right time and again in the right patient. So this has been a long journey. It started with preclinical evidence that patients, or in this setting, preclinical models where BRCA deficient tumors were 1,000 times more sensitive to Parp inhibition. So I wanted to provide this slide for you. Again, you can download the slides of the 9 indications. Think of it. Most of these Parp inhibitors were brought to the clinic in later lines of therapy 3 times. And then we pivoted to platinum sensitive recurrent maintenance 3 times. And then now frontline 3 indications and even combinations. So we're going to sort of provide a high level overview of that. And really the initial sort of recurrent cancer indication was building on the benefit of chemotherapy. It really was creating the benefit of chemotherapy without a decrement in health-related quality of life. See, the trick was that in the historical past, when we did maintenance therapy, you gave a dose of intravenous chemotherapy and had to live with the consequences for the entire cycle. When Parp inhibitors are used as a daily, once or twice administration, if there are adverse reactions such as nausea, you can stop and recover and it gets better. So although adverse reactions occur, the impact on quality of life is rare because they are daily medications and that can be mitigated. So these are the pivotal studies of Parp inhibitors in patients with recurrent disease. Again, I just wanted to provide you with the data as a reference. This is the sort of highlighting the PFS, the median differences, and some of these are very, very impactful. So I want to sort of take that now as our opportunity and begin with the case and really try to make this a practical context. And I'm going to, now involve our discussants who are also going to present to you some new data. BJ, when you see a patient with newly diagnosed advanced ovarian cancer, which we see all too common, what are the key factors that you look at in determining the best treatment for her?
That's a great question, Brad. The key factors that help me determine what I'm going to choose for that patient are both the nature of her disease, the location, whether her disease is amenable to primary cytoreduction, or if neoadjuvant treatment is more appropriate. And then secondarily, we try to obtain germline BRCA testing as well as somatic BRCA testing as quickly as possible to help us understand as early as possible in the patient's disease course what their genomic landscape might look like.
Yeah, that's really good. So Katie, so testing, she mentioned, which obviously is now the new, hence the name of our program today, personalized medicine. What is the sort of upfront, early on testing, both of the germline and the tumor, that we should do?
Well, certainly taking cost into consideration and what each individual patient's insurance will cover. So sort of ideally, you want to do just as Dr. Reimel suggested. So once a patient has a known diagnosis of epithelial ovarian cancer, they should be offered testing for germline deleterious mutations and BRCA1 or 2 at least. And many would prefer that this be a panel test, as there are other genes that are known to be also very predictive of development of ovarian cancer, but also potentially predictive of response to Parp inhibitors, and probably most importantly, identification of those genes confers the same heritable risk to family members. And so you can do cascade testing. So ideally you do a germline panel test. And then if that's positive, that's kind of where you can stop really at this point.
BRCA.
Positive for BRCA, correct. Sorry, thank you for clarifying. If it's positive for BRCA, that's where you can stop. If it is not positive for BRCA, then ideally you would do, again, at least a somatic test for BRCA plus minus testing for homologous recombination deficiency. And I think we'll talk about that a little bit more. In my practice and my partner's practices, we like, again, to do a panel because we want to pick up more than just BRCA mutations. And we can talk about that a little bit more, but there are certainly other genes with quite a bit of evidence towards predictive capability for response to PARP.
So BJ, is anybody just testing for germline BRCA anymore? We're all doing panels, right?
I think we're all doing panels. The cost doesn't seem to be prohibitive, and payers are generally willing to do this for patients, even in the upfront setting.
Yeah, the way it was explained to me, maybe it was you, is that the labs are doing next gen sequencing, and if you just ask for the BRCA result, they'll give it to you, and they just will sort of withhold the rest of the information. And that's why there's really no additional cost, because they have the information anyways. And why wouldn't you want it, to what Katie Moore talked about? But we also have to make the decision early on about bevacizumab. So how do you make that decision? Really is the second decision point, as I say. First is neoadjuvant or primary debulking, or bevacizumab. How do you make that decision?
Well, for me personally, I look at the patient's spectrum of disease. So if I have a patient that's presenting with fluid in 2 compartments, such as a pleural effusion and ascites, or a pericardial effusion and a pleural effusion, I strongly consider that this is sort of a VEGF-mediated disease process, and I will likely give her bevacizumab. That's just been my practice. There's some retrospective data from GOG 218 that suggests that those patients may benefit a little bit more, but again, this is post hoc analysis, and not really, we don't have a biomarker for bevacizumab response.
Well, what a good point. Back to the biomarker issue. Katie, anything to add on that?
I mean, I think that's very reasonable. I'm a little bit more is more. So I think 218 was positive, ICON 7 was positive in all subgroups. So there's really not someone that I don't consider bevacizumab for. I discuss it with patients. It's shared decision making. Some patients are ineligible, of course, and we can talk about that in the combination part of this discussion. But for those who are eligible, we have that discussion about what it adds and what it adds in terms of benefit and risk, and patients can decide what they choose for their therapy, shared decision making. But I like it. I mean, there's not a group I don't use it in, I don't consider it for.
Yep. You know, I've been a passionate advocate for, you know, frontline maintenance for a long time. And I think you really brought it home when you pointed out to me, look, Brad, you know, the biggest impact in the trajectory of ovarian cancer is frontline. So you got to do the best you can for that patient in the beginning, okay? Because in fact, there might even be some patients that can be cured. Certainly that's not the majority, but it's becoming increasingly possible. So this is a patient, 53 years old, newly diagnosed high-grade serous cancer, a stage 4 cancer, and you know, had her tissue testing, which shows that she has a BRCA mutation. So what's the right treatment for this patient, BJ, in your mind? She's young, she's healthy. Whatever the surgical decision is, we'll sort of take that aside. I guess, does this patient need bevacizumab, and does this patient need a PARP inhibitor, or does she need both?
It's a great question. I think I would say that she definitely needs a PARP inhibitor. I would also consider whether or not she's a candidate for intraperitoneal chemotherapy, which may have.
Patient?
If she's fully debulked, I mean, depends on what her stage 4 really was, if it's just a pleural effusion or something else.
Okay.
But in general, I like to give patients, you know, a platinum backbone, obviously. And then I would say that this patient is definitely going to receive a PARP inhibitor from me.
Thank you. So Katie, is intraperitoneal something that you would consider for this patient?
I would consider, you know, in intraperitoneal chemotherapy. It's funny. I trained at one of the biggest centers for intraperitoneal chemotherapy in the United States under Joan Walker. So it used to be something we did routinely, and it's really not anymore. So individually, we do still use IP in very individualized patients, no gross residual. Stage 4, you know, I think to BJ's point or Dr. Emmel's point, it would depend on why they were stage 4, but young, BRCA positive, based on very retrospective, not high level data, but we might consider it, but it's really not something we do a lot of anymore. Interesting to say. Pendulum
it is
completely
interesting
swung.
to say, because we had 3 studies that were positive, which were very intriguing, one of which published in the New England Journal. They were difficult to interpret because they changed multiple things, the dose, the schedule, and of course the route of administration, intraperitoneal versus intravenous. And then we did one study which tried to isolate the effect, and it was negative. So, you know, that's been the controversy. I think it's a reasonable sort of thing to discuss, and you know, we'll probably never study it again. And so there you go. Would this patient get bevacizumab, either one of you?
Yes.
Yeah, probably.
Yeah. So what that does is that if she gets bevacizumab and does well, and you both said she needs a PARP inhibitor, you know, would you stop the bevacizumab when she got a BRCA mutation in the maintenance phase, or would you add the PARP inhibitor to bevacizumab a la PALA-1?
Well, I think prior to May 8th, we would have had to stop the bevacizumab.
That's right.
Because she definitely needs a PARP. You know, she needs to be offered a PARP. You know, you have to share decision making. Patients make decisions, but that is the key part of her care. That is the life extending part of her care, and so that has to come first. So up until May 8th, yeah, I would have stopped because I would have started the bevacizumab because she was stage 4, and then I would have stopped it to give her a PARP. Now I won't.
Yeah. So BJ, you're going to give us that very impactful data, you know, towards the end of the program. Let's talk about sort of single agent PARP maintenance treatment. We have your very nice paper in the New England Journal, really practice changing, unprecedented, and I'm so honored, Katie, that you're with us. And then the PRIMA data also. So why don't you take it away here and tell us about those 2 impactful studies?
Well, thanks. So we're really and we're going to have an interesting conversation today, because the paradigm, when you think about it, in December of 2018, SOLO-1 was FDA approved and became available in the US, and over the last year and a half now globally. And now just in the last few months, we've had 2 additional approvals. And we're going to talk about PRIMA and then PAOLA. And we'll see what happens with Velia maybe in 2021. But in a year and a half, 3 new approvals that have really transformed how we think about treatment of women with ovarian cancer. I think it's getting sometimes more difficult and not clear what our options are. But you talked at the beginning, Dr. Monk, about kind of the maintenance story really gaining finally traction in the platinum sensitive recurrent setting. And Solo One really set it on its course in frontline therapy. So if you think about it, with bevacizumab, which has been around for almost a decade, the first paper from 2018 was in 2011, if I'm not correct. It was one of those things that you could do or not do. Positive progression-free survival, but modest. And so it is still a decision. PARP inhibitor in BRCA-associated cancers, not so much equipoise there. So that came with Solo One initially. And I'll show you the schema for Solo One in the next slide here. So just to remind, I think this audience will know or remember well, Solo One was designed, I'll remind you, in 2013, 2012, 2013. So 7 years ago now, this was designed. It enrolled women with BRCA-associated cancers, advanced stage disease, excellent performance status. They had to have undergone a cytoreductive surgery, either primary or interval. And at the completion of chemotherapy, platinum-based chemotherapy, they had to be in either a complete or partial response. And that response was the key stratification factor for randomization. And patients were randomized to olaparib 300 milligrams twice a day or placebo, and that continued until progression or toxicity. But at 2 years, if a patient hadn't come off for toxicity and had not progressed, the assigned therapy was discontinued, unless at that point there was some evidence that there was disease being held stable or in control, and with discussion, that patient would have been allowed to continue on therapy. The primary endpoint for Solo One was investigator-assessed progression-free survival. Secondary endpoints were several, but progression-free survival 2 was presented with the primary presentation back in 2018. And then overall survival is still very much immature and pending, as well as quality of life, all of which were mature at the time of the primary presentation. This is really the key slide from Solo One. And what this represents is the investigator-assessed progression-free survival for women randomized to olaparib in blue and those in placebo in orange. And so what you can see here, with 41 months of median follow-up, so very long follow-up, we had a difference in the median progression-free survival of not reached, but it was about 47 to 49 months as compared to 13.8 months. The difference in the entirety of the survival curves is represented in a hazard ratio of 0.3, which translates to a reduction in the risk of progression or death of 70% with use of olaparib for 2 years. And so this was an unprecedented improvement in progression-free survival for women with platinum-resistant, with a BRCA-associated ovarian cancer, and very quickly and appropriately gained FDA approval and global approval really across the world for women with BRCA-associated cancer. So a landmark finding and a great team led to this. And so we still celebrate this. However, it is only relevant for women with BRCA-associated cancers. And during the time, I mentioned that the Solo One was designed in 2013 to now, it's been 7 years. We've learned a lot. And you heard from Dr. Monk's section, some of what we've discussed is that it's not just BRCA. There are other DNA damage response genes that are very important, and mutations in those genes may be predictive biomarkers for response to PARP. And there are other changes to a tumor's capability to fix its DNA that are very common in high-grade serous and high-grade endometrioid cancers that may make those tumors also vulnerable to PARP inhibitors. So the next appropriate question was, well, what about everybody else? Well, PRIMA attempted to answer that question. So PRIMA is a kind of similar design to Solo One. It enrolled women with advanced stage ovarian cancer. They had to have excellent performance status. They had to have undergone a surgery, either primary or interval, and they had to be in complete or partial response to their platinum-based chemotherapy at the conclusion. And that, again, was a key stratification factor for the study. The differences are Number one is that PRIMA allowed all molecular subtypes. It actually allowed all, regardless of molecular subtypes. So if you were high-grade serous or high-grade endometrioid tumor, you were included. Also unique to PRIMA is that this study really sought to study the highest risk group of patients with ovarian cancer. Now, I'm just going to go on record as saying I think anyone with advanced ovarian cancer is high risk, and you can see that in SOLO-1, where patients are still recurring. So there's no low-risk ovarian cancer, but PRIMA really tried to identify a group of women at highest risk of recurrence. So they wanted stage 4. They wanted, if you were stage 3, you had to have residual disease at the conclusion of cytoreduction for primary cytoreduction or neoadjuvant chemotherapy. And so the population that is included in PRIMA is very unique. 70% of patients had a neoadjuvant chemotherapy, for example, which is a very high percentage. So the patients were identified. They were completed chemo, complete or partial response, and they were randomized 2-to-1 to niraparib or placebo until progression or toxicity, and in this case, until 3 years, because this is a higher risk population, completion of therapy. As I mentioned, stratified by partial or complete response, but also very importantly, stratified by homologous recombination deficiency positivity, yes or no. So trying to capture that group of patients, not only who have a BRCA mutation, but who also have a vulnerability in their tumor's DNA for self-repair, to make sure that those were evenly distributed through the 2 arms. So that's a key point. So here are the primary endpoints for the PRIMA study, both of which were positive. And so what you can see here is on the left-hand side, this is the progression-free survival in the HRD population. And then you can break this down into non-hypothesis tested, but still very interesting subgroups. And what you can see here on the left is just this group of patients with BRCA-associated tumors, where again, very similar to SOLO-1, hazard ratio here is 0.4, very much in favor of use of niraparib. In the middle, you see those patients who are homologous recombination deficient, but BRCA wild type with a hazard ratio of 0.5, which is still, I know this is not hypothesis tested, but that's still a remarkable improvement actually say a remarkable reduction in the risk of progression or death with addition of this asset in this group of patients. But most interestingly, even in those patients who by this assay were determined to be homologous recombination proficient, you still see a benefit with use of niraparib with a hazard ratio of 0.68, which kind of points to our difficulties with classifying or categorizing patients using a cut point amongst a continuous variable, which is homologous recombination deficiency. So it certainly does identify patients who will benefit more, but it doesn't identify the patients who won't benefit at all, which is why we have an all-comers indication for this agent, because you can see here benefit in all groups. So as I mentioned, in April 28th of this year, 2020, niraparib did gain FDA approval for maintenance therapy for women with advanced epithelial ovarian cancer who had a complete or partial response to platinum-based primary chemotherapy, and it would be used until progression or 3 years. So those are the 2 monotherapy options for maintenance. So very exciting. We now have monotherapy options for all patients with epithelial ovarian cancer. And so as the availability of PARP inhibitors really broadens into the front line, we need to understand how best to utilize these agents so that our patients feel their best and maintain dose intensity and maintain compliance so they get the most benefit. And so this is really well known, I think, by those of you watching this now. PARPs have been approved for a while, at least in the recurrent setting. So what we see across the board when you look at PARP inhibitors are very common, but very low grade toxicities such as fatigue, nausea, constipation, and then hematologic toxicities are anemia and thrombocytopenia. And so really spending time and counseling patients and setting expectations about the fatigue. It's worse the first month and it starts to get better in the second and the third month. Same with the nausea. It's very rapid onset. It's worse in the first month. And then you figure out if you need antiemetics or dietary changes. And over time becomes this sort of dole roar in the background. Constipation can be managed with over-the-counter medications. Anemia, we run into grade 3 toxicities about a quarter of the time, across the different PARP inhibitors. And so when you think about that quarter of patients, about 2/3 of them will require a transfusion. So anemia is not incredibly common, but it's not rare either. And then thrombocytopenia for olaparib, anyway, grade 3 or higher is very low, less than 6%. But this was much higher with niraparib owing to its potency initially with the initial studies. But what was discovered, and this comes from the NOVA study, and Dr. Monk mentioned this in the introduction. NOVA was the first study to report out benefit of use of a PARP inhibitor in platinum-sensitive recurrent disease with a tremendous hazard ratio, and it led to an approval there. But it also had a higher level of grade 3 or higher thrombocytopenia than one would like. And so it was evaluated in something called the radar analysis. A lot of factors were studied, and what was ultimately determined was that patients who had either platelets less than 150,000 at the beginning of niraparib or a baseline weight of less than 77 kilograms, either one of those they're at higher risk for thrombocytopenia, and they should get what we now call individualized dosing, which is starting at 200 milligrams once a day, as opposed to patients who have neither of those risk factors who can start at 300. And so that was published and discovered 2/3 of the way through PRIMA, but because it was a safety issue, the study was appropriately amended. And you can see now several public presentations, at least, have demonstrated it's over 100% reduction in the prevalence of grade 3 or higher thrombocytopenias, 48% in PRIMA down to 22% with individualized dosing. And so that individualized dosing has definitely been shown to be safer. And in very interesting analyses that were presented this year at ASCO, the efficacy of patients who were started on 300 and either stayed or reduced, so started at what's called the fixed starting dose, as compared to those patients who had an individualized starting dose, was assessed, and there was absolutely no interaction between efficacy and the starting dose, which tells us that not only is individualized dosing safer, it's just as effective as starting at 300. And what sorts of adverse events are patients willing to tolerate in order to get benefit? And you can kind of see on the left-hand side, there's the perception of adverse events that are most bothersome, going up, least bothersome at the bottom. And fatigue is up there. Nausea is up there. So these are bothersome side effects to our patients when we go through structured interviews with them. Factors that influence dose making or influence decision making by a patient really comes down to kind of the likelihood of adverse events, the need for extensive monitoring, et cetera. So how much bother is it going to be for them to maintain safe and efficacious use of this drug? How much and how significant are the adverse events that they're going to experience? And so this is really where counseling and really setting expectations and setting patients up for success with preventative measures and starting at the right dose so you don't have to unnecessarily suffer AEs is incredibly important. And as we push out more and more information, this will be an easier conversation to have, so patients feel like they've gotten all the information that they need to be successful with this therapy that can be, thus far we can say, life progression-free survival prolonging, and we hope we'll be able to show that it's life prolonging as well.
Is it true that every HRD patient should be strongly considered for PARP maintenance frontline?
I think that this is a very individualized question. As Dr. Moore mentioned, I think that shared decision-making is important with our patients, especially in a society where at least 60% of our patients will have their employment be the source of their insurance. Yeah. And so when people are trying to manage decisions about whether or not to go back to work or how to care for their children or their parents, We need to be able to acknowledge that some of these adverse events like fatigue and nausea, even if they're grade 1 or grade 2, that dull roar, that constant need for daily anti-nausea medications may still make the choice to tolerate maintenance therapy, especially in the long term, where many of these patients will be on maintenance therapy, God willing, for 2 years, maybe 3. We need to deeply acknowledge the effect on their quality of life and how that may affect them in their ability to get things done. And that includes maintaining their insurance by being able to stay employed.
Is there a decrement, Katie, in quality of life in these studies?
So that's a great question. And we didn't put, there's so much data here, we didn't put any in, but the summary statement is no. It's been looked at certainly by the standard TOI sorts of scales as primary endpoints in all of these studies, and then in the platinum sensitive, and we'll see these in the frontline studies come out, the Q-twist analyses and twist analyses have been presented that really show no difference in quality of life, and that the time spent without symptoms, and the symptoms are ones that we pick, so we have to acknowledge that for the twist analyses, it's just so much greater than the time spent with symptoms that the toxicities that are there appear justified by the tools that we use. I think that's sort of a key thing. We don't really have the perfect tools yet, but thus far it would indicate no.
So, and you're right, BJ, we can't push patients, right? It's easy to sort of layer on your bias. I get that both ways. But what's the strength of the recommendation, do you suppose? Put that into words for our listeners in the HRD subset. What's the strength? Is it?
I think the magnitude of benefit that we're trying to communicate to patients is this is a daily medication where the symptoms that you may experience may be long lasting, but we have medications or strategies to mitigate them. But the magnitude of benefit an HRD positive patient may experience may be the difference between years of life, we think, and less than that. And I think that there's just a lot to be given to that weight, the amount of benefit a patient may experience.
Yeah. So let's go ahead and turn to the questions from the audience. I think as BJ and you too, Katie, have highlighted, it's all about the patient experience, and that we're really fighting two things, right? We're fighting, treatment-related adverse reactions and disease-related adverse reactions. And it's a balance. So Katie, what do patients say about their experience being on a Parp inhibitor?
Yeah, I mean, I think my patients and my partner's patients, and we have a lot of support, so I do have to couch that. It's a very different practice. I think their experience is what we would expect. We kind of set them up for success as much as possible.
Right.
I'll tell you and this will come out of the frontline studies as all of these sort of secondary analyses start rolling out, which are so interesting. But in the platinum sensitive studies that we have beautiful data on adverse events and the timeline of them. So the onset, nausea starts within 3 days on average with olaparib. It peaks by 2 weeks. And then you see this gradual decline as you get into the 3rd month. Fatigue starts at 2 weeks. You see the anemia hit at 3 weeks. And so I actually show some of those time graphs to patients as I'm counseling them. I have a flip chart because they can visualize that. It's actually very good patient-centered data, because then they go, okay, this first month may really stink. And I may have to call a lot, but then they're going to interrupt my dose if it's too bad, or they may have to reduce my dose, or they may add a medication. But by the time I'm in the 3rd month, I'm going to look like these very short bars and I'm going to do well. And that's really what I see. But we really try to set our patients up for success with setting accurate expectations. Like the first month may not be fun. We got to figure it out. Everyone's different, so that if they're like, I'm great, you're like, awesome. If they're like, ooh, you're right, I really felt crummy for 2 weeks, but now I'm better. And they don't feel like they've had the rug pulled out from under them.
Yeah, that's why managing sort of the personalized dose with niraparib was meaningful to me, because I thought we got to the sweet spot quicker. And I set the expectation that I'm not going to tolerate any decrement in your life. If you can't take care of your kids, if you can't work, if you can't travel, I don't want it. And my experience is that with, supportive care, but most importantly, interruptions and reductions and occasionally discontinuations, we can do that. BJ, what's your sort of input or experience in what you hear on a patient on a PARP inhibitor?
I totally agree with both of you that like setting our patients up for success, reminding them that we have medications to mitigate this, that fatigue can be mitigated with starting some, simple but real exercise, as well as giving grace within your schedule to take naps as needed. Those are really important things. I do have a lot of patients that don't want to stop their dose. They've seen the curves, they don't want to stop. And so, we have to do a lot of work together to support them to stay on their dose.
Yeah, that's really good. Thank you both. And, just for our audience, these individuals have been, I guess, and me too, we've been involved in developing PARP inhibitors now for 6 years. So this is not a new medication for us. And olaparib, as you know, is now approved in 4 tumor types, 7 indications. So there is a lot of experience. I, even though I don't treat pancreatic and prostate cancers, I'm very excited about that expanded opportunity. And all of those are biomarker driven. This is patient 2. We've kind of already talked about it. We talked about sort of what we would do in the BRCA setting. Now she has HRD non-BRCA. Katie, you said that, the differences were not a lot different. Does the strength of the recommendation change if it's HRD non-BRCA versus, HRD BRCA, Katie? I'm going to ask you the same question, BJ.
I think, yes, the strength of the recommendation for both is incredibly strong. So HRD, inclusive of patients with BRCA-associated cancers, is very, very strong. But, if you look at just PRIMA, the difference is 0.4 hazard ratio and 0.5 hazard ratio. So 0.4 if you have the BRCA, 0.5 if you have the just HRD BRCA wild type. And so that's a 50% reduction in the risk of progression amongst a group of patients who admittedly are at very high risk for recurrence, but that's an incredibly strong recommendation. So it does change it, but they're still both over the line in terms of, there's not really another option. I think that one of the things we talked about earlier, Brad, that you brought up, that is the strength of the recommendation of the provider.
Yeah,
I think that's critical here because if you look at NCCN guidelines, you could do, and these are all on there now. You can go look at them right now. You can do olaparib, you could do niraparib, you could do olaparib, bevacizumab, or nothing. Like nothing is an equal option.
Yeah, right. I call them options, not guidelines, because they really don't provide weighted recommendations, which is very challenging for patients.
Right. So I think shared decision making does require your opinion. Like, I think that's the hard thing sometimes, because patients will say, my patients all the time, well, what would you do for your mom?
Right.
I hate that question, but it's the right question. What would I do for my mom? Right question.
And I'm really concerned that providers insert their bias, especially me, right? I like maintenance, so don't be too strong. But the opposite is true if you don't be too negative. So it's a balance. Go ahead, BJ. What's the strength of the recommendation if they're BRCA wild type HRD versus BRCA mutated HRD?
Well, I agree with both of you. I mean, this is a 50% risk reduction in progression. It's a wonderful opportunity for patients, but you're also right that we have to say there are other options, and our recommendations have to sort of match what the patient is looking for as well, knowing what's important to them and trying to counsel them and know their goals.
Then I'll ask you a tougher question. What's the right treatment for HRP?
So I don't know that I have an answer for this, but we do have options. And we have options that aren't just nothing. So that's an exciting time.
Yeah, it probably comes down to certainly nothing, which just doesn't feel good. But I get it, Katie, as you described, that the difference of niraparib, which is really your only PARP inhibitor option because olaparib is not indicated. Of course, neither is rucaparib. But you can give bevacizumab, right? Mm-hmm. So it really is niraparib versus bevacizumab. How do you make that decision, Katie, in HRP?
Yeah, I think HRP is number one, a group of patients we need to identify more clearly, because
Yeah.
I think what the PRIMA study to me is clear about is that we don't identify patients accurately, because clearly there's women who are in the HRP group who are not HRP. They just were misclassified. So I want to study that group and identify them more accurately and figure out why they have such intact DNA damage repair capabilities and how we can target that.
Yeah.
Until that point, I think your options are, as BJ alluded to, Bev or niraparib. And you can look at it both ways. I think this is clinical equipoise. On one hand, you say, you know what, this may be the only opportunity that you ever will have to get a PARP.
Right.
Because if you're not platinum sensitive, and some of them will be, because we know there are homologous recombination proficient patients on all of the platinum sensitive studies. So some of them will make it, and they've declared themselves as the ones who will likely benefit.
And they have to respond a second time to platinum.
And they have to respond to the same.
Yeah.
So it's a fraction of that group of patients that we identify in the front line. They're in there, but I don't know what fraction they are.
Right.
So I'm going to overtreat some of them to maybe get better benefit of the PARP earlier, because we know PARPs work better earlier. So I may get a longer benefit on PFS than I would if I caught that group who's going to benefit later. But I'm probably overtreating a group of patients. Yeah. So I think that's one option. On the other side, if I'd started Bev, because I've already made the decision to start Bev.
Yeah, that's helpful.
Right before I know.
Just keep it going.
That I probably wouldn't stop it.
Yeah.
So that's how I think how I'm going to approach it until we have a clinical trial open in this space, which I hope we will soon.
Yeah, with your leadership. Thanks. So BJ, I don't want you to think I was being easy on you. So I'm going to keep giving you tough questions. So, okay. In the recurrent setting, it was challenging because we had 3 PARP inhibitors with exactly the same indication. Solo 2, Study 19, NOVA, and Ariel 3. We actually still have that in frontline. We have that if you're not on Bev, and you have a germline or somatic BRCA mutation, you have the option of either olaparib for BRCA mutated patients or niraparib, and they're both, level 1 within the NCCN. So there you have to choose, and you already told me that patient needs to be strongly considered for a PARP inhibitor, but which one, olaparib or niraparib if they have BRCA mutation?
I think I often will talk to patients about what's difficult for them with taking oral medications, because once and twice daily dosing can actually make or break it for a patient. For some patients, they have great support and twice a day is easy. For some patients, maybe their caregiver only comes once a day and they need their medications distributed once a day. There are sort of social factors that can help me make those decisions.
And to be clear, niraparib is a once daily medication, but also familiarity. Some people are more familiar with olaparib. So because the solo 1 indication was first, but let's keep rolling. I think that really gets to the issue. Maybe we should do both. And this is a study also presented at ESMO 18, published in the New England Journal, 19, published in the New England Journal in December 19 and approved on May 8th, 20. So tell us about PALA-1, BJ.
Sure. So this is the results from the PAOLA. The inclusion criteria were newly diagnosed FIGO stage 3 and 4 high-grade serous ovarian carcinomas. These tumors were stratified by BRCA mutation status in the tumor and also stratified by treatment outcome CR or PR. Patients were randomized then 2-to-1 for olaparib twice daily with bevacizumab versus placebo. The primary endpoint was investigator-assessed PFS, but there are some really exciting secondary endpoints, such as OS and health-related quality of life that will result out later. The results demonstrated that for patients that had HRD-positive tumors, including tumor BRCA mutations, that they had an excellent response and a dramatic decrease in the number of progressions. And that included patients who did not have tumor BRCA mutations, but were just HRD positive. For those who were homologous recombination proficient or HRD negative, the addition of olaparib didn't seem to add much to bevacizumab. But what this study doesn't have for us is an olaparib alone arm to help us understand the contribution of olaparib as it stands to this active control of bevacizumab. Patients tolerated this combination very well. and both groups had similar numbers of treatment-related adverse events with similar numbers of dose discontinuations. Interestingly, the same adverse events that we would expect were seen, with fatigue, nausea, and hypertension being the most common. It is interesting to note that hypertension was a little bit better in the combination than in the bevacizumab alone arm, but the rest of the adverse events are just as would be expected, with no increase in grade 3. We see again that in Paola-1, approximately half of the patients were HRD positive. This was all assessed via the Myriad MyChoice HRD test, and this keeps coming up, that we see about half of patients with these high-grade epithelial ovarian cancers having a homologous recombination deficiency. Very consistent with what's been seen in other studies. So on May 8th, the FDA approved this combination of olaparib in combination with bevacizumab for the first-line maintenance treatment of our patients with advanced epithelial ovarian cancers who have responded well to their first-line platinum-based therapy, who had HRD positive disease. And the companion diagnostic Myriad test was also included in this approval. A similar study using a different Parp inhibitor was Ovarian that looked at the use of niraparib plus bevacizumab in a similar population of patients who completed their first-line platinum therapy, who were also had bevacizumab included for at least 3 cycles. These patients, the primary endpoint for this study was progression-free survival at 18 months, and we only have the interim analysis for these patients with a very striking PFS rate of 89.5%, very similar to what was seen in the Paola-1 study, but obviously the results are not mature yet, and we'll have to see what comes next for this study.
Yeah, that's great, BJ. That was very clear and very impactful. You know, that study was done in Europe because that's where bevacizumab was approved at the time. Do you think that study is applicable to the US population?
I think it's a good question. I think that the use of bevacizumab in the United States does still seem to be less, although now that maintenance therapy seems to be more what the standard will be, I wonder if we'll see an increase in the use of bevacizumab here. It'll be interesting to see what happens as people start to become more familiar with the data from Paola-1.
Yeah. So Katie, these indications are obviously very different for PRIMA, all comers, but for Paola-1 HRD. And as BJ nicely stated, there really was no benefit in the HRP subset. So as I sit here and think about it, and as she's presenting, I'm like, why didn't olaparib work in HRP? And so I wrote down maybe 3 possibilities. There might be others. One is that the bevacizumab negated the effect. Bevacizumab has been sometimes called the great equalizer, so it really was not synergistic as we had hoped. The second is the patient population. You know, cross-trial comparisons are inappropriate because the populations, the types of patients that are enrolled are different. And then 3, you know, the elephant in the room is maybe niraparib has a stronger PARP trapper, more enzymatically active. And the reason olaparib didn't show a benefit in HRP because it wasn't niraparib. There might be other explanations, and we don't know the answer to that. But I would like your insight on why you thought there was no benefit in the olaparib in the half of the patients that had homologous recombination proficiency.
I mean, it was surprising. I think we have to remember, number one, that PRIMA was compared to placebo.
Yep.
And as I alluded to earlier, I really have a lot of doubts about the classification of tumors based on a dichotomization of a continuous endpoint. And so I think I would like to know the scores of the patients who are in that group, because I'm wondering if that is telling.
That's a good point.
And to your point, cross-trial comparisons, I don't know who was actually accrued in the HRP group in Paola and what was their makeup. So I just think that it's a very difficult question to answer. In Paola, that was a non-hypothesis tested endpoint. There was no control for other prognostic indices. So it certainly looks like there's no benefit, but I just think it's one of those things that it's difficult to say. And it is compared to an active comparator, and Bev may be better in a true HRP population than a PARP. Like if your tumor can fix its DNA and it's really awesome at it, why would a PARP work? at all.
Yeah. I mean, I like the FDA indication because it turns that HRD assay into a companion diagnostic. And by being a companion diagnostic, CMS and really all insurers basically pay for it. So it was always a companion diagnostic in Quadra since October, but that really expanded it. We have some questions from the audience. I think, Katie, you said, and BJ, that, you know, early on, panel germline testing is important, and only if the germline BRCA1 or 2 is positive, then immediately reflex to tumor testing. I think the issue is what that tumor test should be. And again, I love being in this role because I can put you guys on the spot, and you guys are we're friends. You don't take it personally, but I'm just, these are the questions that everybody has. So I'm just having fun. You know, what's the right test? Some people would say, well, duh, you should use the test that was studied. Other people would say, well, you know, I'm not sure that the tests are really different. You said, Katie, something that's very interesting, that you want the other mutations associated with, let's say, you know, next-gen sequencing rather than the HRD assay. Do those mutations matter now at early diagnosis when you need them in 3 years after 3 lines of therapy, or do you need to retest the patient again, let's say with the foundation medicine, to really find the mutations that are present in the tumor then, rather than the mutations that were present at diagnosis?
Yeah, I think that's a great question. Right now, I think if in the future, if we have new companion diagnostics, for example, I'm very hopeful that ERBB2 amplification will show that it is effective in our patients with ERBB2 amplifications. And so that will be a companion diagnostic and I can order it. Yeah. But, you know, I personally have had, and I don't have a lot of trouble getting NGS for patients. I do have trouble getting it repeatedly done, and I do get denials there. So, to your point, do I need it right now? Most likely, no. You're kind of looking for the needle in the haystacks there. But will I use it? Do I use it? And it's in every note. It's what I'm going to use as I'm following that patient later. Yes. So in an ideal world, I probably would just get what I need now, and I test everybody at the time of recurrence if they've not been tested prior. But I don't necessarily rebiopsy them unless there's some compelling reason to do so, because we've not shown in any setting for ovary cancer that the treatment that we're using causes any sort of genomic pressure that other than BRCA reversions, which we can't even pick up on NGS. So the one thing we know happens with treatment, we can't even detect on commercial tests. So I'm kind of torn. I agree with your point in your question in terms of the point you're trying to make. But pragmatically, I want to get everything I can and sort of line options up for my patients.
Yeah, I hear you. And so on April 10th, 2020, before the PRIMA and PAOLA-1 approvals, ASCO, you know, published in the Journal of Clinical Oncology the guidelines, and you know they were very nice in the germline testing, and you know they inferred that a panel was preferred, and that's fine. They really didn't talk about HRD testing because it really wasn't, even though the papers were out there, but it was an NCCN 2B recommendation at the time, and again, we really didn't know it was going to be a companion diagnostic, as it turned out. So I hope the NCCN goes ahead and updates the recommendation. And I also hope that maybe ASCO updates theirs. This is the assay that was studied. You said, BJ, Myriad MyChoice HRD. It's not a functional assay, surprisingly. It is a genomic scar. And to your point, Katie, that it's created in the beginning and it never changes. So that's why it's more predictive and prognostic, but it's more predictive of PARP sensitivity sort of in the beginning, because the scar never goes away. And that's why the FDA calls it genomic instability. But it's really an HRD assay that's what we've named. And it's 3 things. It's where the chromosomes don't line up, there's loss of heterozygosity, and even large state transitions, big chunks that are missing. And because the telomeres are particularly unstable, they can be imbalanced. And it creates a score the score and the cutoff to what you said, Katie, is 42, but they don't give you the number. It would be nice if they gave you the exact number, because the sense is that the higher the number, the more impactful that a PARP inhibitor would be. BJ, give us your assessment of these. There are a number of them. I don't want to get too much into the commercial opportunity, but this is a companion diagnostic, so we can talk about it sort of as in a CME program. What's your preference in frontline somatic testing, tumor testing?
This is something that's still undergoing a lot of discussion at my place, because all of us feel a little bit differently. When we're thinking about getting those upfront NGS tests, the companion diagnostic test is available, but if we decide we want another molecular profile later, sometimes we can't get that paid for. And so we have a lot of discussions with patients, even sometimes, look, if we knew that you were HRD positive, we could say you had this magnitude of benefit with PARP, but if we hold our money now, we might be able to test your tumor, in a later line of therapy if something else comes along. So, we've been having these conversations in our office. It's very challenging to decide which is the right thing. But currently, we are trying to get our HRD assay at the same time that we get our germline and our tumor testing, so that we can get it all at once to have that conversation at the end of chemotherapy.
I think both of you have great perspectives. Katie says, look, it's not perfect. You say it's rapidly evolving, and my answer is yes. Clearly, this is a rapidly evolving space. I want to share with you very briefly some new data that was presented at ASCO. Just like PALA-1 was an evaluation of a PARP inhibitor and anti-VEGF, within the energy, GY004, they did the same thing, but this time with an oral anti-VEGF therapy in platinum-sensitive relapse. Again, comparing it to chemotherapy, because we really like these sort of non-platinum opportunities and even non-chemotherapy opportunities. And we were very intrigued by the fact that there was no difference. There were some people that say, well, it was just as good. Obviously, that's not the way that it was designed. And we learned, that these oral TKIs can have a whole unique set of adverse reactions not seen with bevacizumab and PALA-1, such as diarrhea here. We just published SOLO-3, which is a comparison to chemotherapy also. And the development of olaparib was sort of stalled because we thought it may not be as good as chemotherapy. When it got accelerated approval in 2014 on a single-arm study of 137 patients, the FDA says, well, you really need to study it versus chemotherapy. So we did that in platinum-sensitive disease, but we didn't include platinum. So I get it that they had at least 2 lines of therapy, and maybe you can use a non-platinum in that setting. But it was very, very encouraging that there was an improvement in the response rates and ultimately progression-free survival. So we continue to do this, to study sort of PARP inhibitors in a platinum-sensitive relapsed disease. And we've always had uncertainty whether there was an improvement in survival. And also at ASCO was a presentation SOLO-2, which you're familiar with, led to the approval in BRCA-mutated patients in recurrent maintenance. And look at this, 12.9 months of improvement in overall survival. And I like the way Paveda presented it, because it's not statistically significant, but no one would say, really, it's negative, ignore it. No way. This, even though it didn't cross the statistical threshold, this is clinically important. This is meaningful. This adds confidence. This gets us really excited, Katie, more about the overall survival of SOLO-1 someday.
Yeah. Okay, the other thing here, Brad, is I agree with you. Our good friend Rob Coleman gave us a great article called "It's Time to Retire." The p-value after this came out, because this is just so clinically, who cares what the p-value was? But this is unadjusted for prior PARP.
Yes.
So it includes the 35% of patients, or what I can't quite see, who received appropriately a prior PARP. So that idea that you can just layer and layer and layer and just wait to use these things. Well, this is the natural history when you wait. If you wait, you still do better if you use it earlier. So this completely reinforces the necessity for using PARP in earlier lines of therapy, and it's just critically important messaging.
Yeah, and the differences over time in landmark analyses was impactful, and that was reviewed. We always throw in the safety. There were no new safety signals identified, except there were some MDSs and
Right.
AMLs.
Right.
Tell me, I'm sure, BJ, that creates concern, right, for you and your patients?
Very much so. We've had some MDSs and AMLs in our practice, and they're all very alarming, to say the least. So it's an area that needs to be considered, although the numbers still remain very small.
Yeah. Any comment, Katie?
There's a lot of work right now that I can't bring into the public domain to try and combine across programs to really get a sense of what the numbers beyond the safety follow-up was. Because what this data showed was the AML risk during safety follow-up, but then now they're reporting it beyond safety follow-up. And so what you see there is it's the same in the placebo group and in the olaparib group, it's 4%. So there is this baseline risk, and this may be just particular to patients with BRCA-associated cancers, germline. I think we need to see so that 8% isn't entirely related to the olaparib. There's some baseline risk that we're beginning to understand better. So I think more to come on that.
I wanted to just mention rucaparib. Rucaparib has an ongoing phase 3 frontline study, which all of you know about, Athena. There's great hope of adding nivolumab to rucaparib. Athena also has integrated into it sort of a PRIMA-like design, so Parp inhibitor versus placebo. So I just wanted to put this into sort of their treatment indications. This was presented at ASCO, talking about the long-term responses and really emphasizing that there was a real opportunity in the germline molecular subset. And I think this, these swimmer plots are very telling. So Athena is here. Also, the other rucaparib study, which is Aerial 4. Aerial 4 differs from Solo 3 because it actually includes a platinum agent in the physician's choice chemotherapy arm. But I think you see the layering of now checkpoint inhibitors ongoing, first and Duo. Mediol and Topacio is combinations in recurrent disease, and then Key-Link is frontline maintenance. So yeah, so I want to thank the audience. I also really want to thank our participants. We tried to create some different sort of perspectives. I think you saw that. We wanted to create some different geographic locations, no question. I really enjoyed it. I think we were able to demonstrate that PARP inhibitors are effective. They're effective in treating recurrent disease, in recurrent maintenance, and they're especially active in frontline maintenance. And that they work the best in BRCA patients, either germline or somatic, but they work pretty good in HRD patients and even occasionally in HRP. But it all starts with testing. Tried to weigh the different types of tests that are available. I think we all agree, though, that testing is important and really that the era of personalized medicine is here. So thank you to our audience. On behalf of Drs. Reimel and Moore, this is Brad Monk. Thank you for joining us, and so long for now.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/QYX860. This activity is supported by independent educational grants from AstraZeneca, Merck & Company Incorporated, and Myriad Genetics Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education.